So, good evening, everyone. Hope you all are doing well. In today's session, we are going to talk about the guidelines surrounding diabetic retinopathy, management, and monitoring. And this was published by the NICE in 2024 on the 13th of August. This is a very important set of guidelines for clinical practice as well as for the upcoming specialty certificates and European board exams. And this is overall my lecture number 85 of my lecture series. So the guidelines had the following recommendations. They have dealt in detail with managing diabetes to support best eye care. In this, they have spoken about the targets for the blood pressure, targets for the glycemic control, as well as the role of fenofibrate in the management of diabetic retinopathy. In the section 2, they have covered the cataract surgery for people with diabetic retinopathy or diabetic macular edema. Then in section 1.3, they have covered how to treat the active pathologies in each eye. In section 1.4, the non-proliferative diabetic retinopathy, they have covered when and at what stage to refer and the monitoring frequencies. They have covered in detail about management of proliferative diabetic retinopathy and about diabetic macular edema, which is a very importantly asked topic for the specialty exams. So we'll be going through each of these sections via case-based approaches, and we'll try to deal with different case scenarios which will implement these guidelines so that you can better understand it. As you're well aware that my Mastering Endocrine and Diabetes lecture series now comprises of total of around 85 lectures uh, covering different topics and frequently asked question scenarios in the exams. So there is an extensive list of lectures for thyroid, for the adrenal gland, for the pituitary gland, covering in length the all aspects of diabetes, the different guidelines, JBDS as well as NICE, and each and every guidelines is via case-based approaches. Then there are sessions on calcium regulation as well. There is almost around 15 to 16 lectures where I have recalled the previous exams. There is sessions on exam lab question and answers with explanations. These are very important set of question and answers frequently asked in the exams. There is some pearls from the Oxford Handbook, 4th edition, and different sessions on quick exam revision as well, along with a mock exam. So quite extensive lectures which will cover the full spectrum, which will be important for your exams. Lectures in reproductive system, lab endocrinology, genetic syndromes, and immune checkpoint inhibitors, along with lipid disorders, including the latest guidelines in NAFLD. So that is almost comprising of 85 lectures for my Mastering Endocrine and Diabetes lecture series. So let's start right away with the session today, where we are going to talk about management of diabetic retinopathy, the NICE guidelines which were published in 2024. Now, in this context, the first part which I'm going to cover is the section 1.6, which deals with macular edema. So first and foremost, what do we understand for the clinically significant diabetic macular edema? So diabetic macular edema is clinically significant when any of the following signs are present based on the slit lamp biomicroscopy with stereopsis. If the retinal thickening is at or within 500 micrometers of the center of the fovea, if there is hard exudates at or within 500 micrometers of the center of the fovea with adjacent retinal thickening, and if the retinal thickening is of one disc area or more within one disc area of the center of the fovea. All these three statements, if any one of them are present, then it is clinically significant diabetic macular edema. It's very important to remember this definition which is mentioned in the guidelines as well, because this has been asked several times in the previous exams. So overall, a brief overview of the management is mentioned here. We'll be looking in detail how to divide the management based on the NICE guidelines. So for the person with clinically significant macular edema, they have divided the management into three types. One is those who have a center involving macular edema along with visual impairment. We'll look at what is the meaning of center involving macular edema in the next slides. The second is those who have a center involving macular edema but with good vision. And the third aspect is a non-center involving clinically significant macular edema. So the treatment and the approaches differ in each of these three categories, which has been asked in the previous exams. And that's why it's very important to note each and every part of this guideline. Will help you in your clinical practice as well as the exams. So let's start, as we always do for all our lectures, case-based approaches. So case number one is a 58-year-old male with type 2 diabetes presenting with worsening central vision loss. Optical coherence tomography or OCT shows a center involving diabetic macular edema with a central retinal thickness of around 420 micrometers. So we already know that first we have defined clinically significant macular edema. Now we'll look at what is the meaning of center involving diabetic macular edema. And this patient also had a central retinal thickness of 420 micrometers. So what is the most appropriate initial treatment in such a case scenario? Should we offer the patient macular laser therapy? Should we offer intravitreal anti-VEGF therapy? Should we do observation and just repeat the OCT in 3 months? Or should we proceed with vitrectomy? So what's the correct answer? As per the NICE guidelines, it is intravitreal anti-VEGF therapy. So explanation is as follows. We'll look in detail the guidelines in the next slide pertaining to this topic. For center involving DMO with visual impairment as our patient and a central retinal thickness of more than or equal to 400 micrometers, our patient had a thickness of 420. Anti-VEGF therapy is the first line treatment in this regards. Now, this comes from guidelines. But first of all, what is the meaning of this central retinal thickness and why it is significant if it is more than or equal to 400 micrometers? So a CRT or a central retinal thickness of 400 micrometers or more is clinically significant finding that often indicates retinal edema or swelling. A CRT of 400 micrometer or more often indicates severe macular edema, warranting prompt treatment like anti-VEGF therapy to prevent irreversible visual loss. And that's why it's very important to note in the question stem what is the CRT they are mentioning, which will decide our first line management. So the term specified has been defined in the guidelines. What do you mean by center involving diabetic macular edema? So diabetic macular edema that involves the central subfield. So what is central subfield? It is a circle with a 1 millimeter diameter, and this represents the most central part of the macula where the fovea, which is basically responsible for the sharp central vision, is located. And that's why there is a big significance of this central subfield. So if there is a diabetic macular edema that is involving this central subfield as per the ETRS grid, which has a diameter of 1 millimeter, as I mentioned, then that is referred to as center involving diabetic macular edema. And of course, this is always clinically significant. As I mentioned, there is a lot of clinical significance of this central subfield because it has a direct impact on the vision. It is essential for the fine visual tasks like reading, recognizing faces, and detailed work. And swelling in this particular area can cause central vision loss, distortion, which is referred to as metamorphosia, or even reduce contrast sensitivity. Hence, it is extremely important to take this into consideration and target with immediate intravitreal anti-VEGF therapy. Now, guidelines, as I mentioned, clearly specifies if the person is having center involving macular edema and visual impairment as our patient, central retinal thickness of 400 micrometers or more, immediately offer anti-VEGF therapy, as was the answer in this question. On the other hand, if the central retinal thickness is less than 400 micrometers, consider either anti-VEGF, or even we have an option of offering the patient macular laser. So here we have two options if the retinal thickness is still less than 400 micrometers. If the person cannot have non-corticosteroid therapy, then in that context, consider an intravitreal steroid implant. I will talk more detail about this statement in the next slides and the indication and the reason to put an intravitreal steroid implant for in context of retinopathy. So the anti-VEGFs, which have so far been licensed for the visual impairment due to macular edema, are ranibizumab, brolucizumab, faricimab, and aflibercept. Use of any other anti-VEGF treatment will be off label. Moving on to case scenario 2. Here we have a 62-year-old male with diabetic macular edema. He was already started now on anti-VEGF therapy. After completing the loading phase, OCT was done, which showed persistent edema with only minimal improvement in the central retinal thickness. So then in that context, the patient has not a good response to anti-VEGF therapy. So what should be the next step? Should we still continue anti-VEGF therapy without changes? Should we consider macular laser as an adjuvant therapy? Should we stop treatment and observe for spontaneous improvement, or should we refer for immediate vitrectomy? So again, as per guidelines, we should consider macular laser as an adjuvant therapy in addition to anti-VEGF therapy if there is no initial response with the anti-VEGF therapy. Vitrectomy is, of course, reserved only for cases with complications such as vitreomacular traction or epiretinal membrane. So this is the chart from the guidelines which specifies more in details the thing which we mentioned. So if we come down to the after the loading phase is finished, we assess the response to anti-VEGF therapy. If there is a suboptimal response, as in our patient, and that is the definition that the patient did not have proper response, we should consider macular laser as an adjuvant therapy and then move forward. All right, so this is very, very important that we note that if the patient has a suboptimal response, consider macular laser as the adjuvant therapy as defined in the guidelines. Moving on to case scenario 3, here we have a 65-year-old male with diabetic macular edema, has been on anti-VEGF therapy for several months. His visual acuity continues to decline and OCT shows progressive retinal thinning and atrophy. So here there are some warning signs which we should take into consideration. So it is beyond deterioration of visual acuity. I mean, there is also retinal thinning and atrophy. What is the best course of action in this scenario? Should we still continue anti-VEGF therapy and reassess in 3 months? Should we consider vitrectomy before permanent damage occurs? Should we switch to macular laser therapy, or should we stop treatment and refer to the low vision services? So we should definitely consider vitrectomy in such cases before permanent damage occurs. So these are some of the warning signs which have been asked in the previous exams as well of permanent damage. We should be aware of this, like macular retinal, for example, retinal thinning and atrophy, more precisely photoreceptor loss, macular atrophy, and lamellar macular holes. So these are some warning signs of permanent damage which you should look for, and early intervention with vitrectomy should be considered in such case scenarios. So again, we can clearly see here if the patient has um poor response to anti-VEGF, and if the patient is having warning signs of permanent damage as was defined. Also, if the patient has either vitreomacular traction or epiretinal membrane developing, then all these are scenarios for considering vitrectomy. We'll be trying to see what is the role of intravitreal steroid implants like the fluocinolone acetonide and dexamethasone in the next case coming ahead. So here we have a 58-year-old female now with a center involving diabetic macular edema and visual impairment has received anti-VEGF therapy for almost 12 months. She reports difficulty with frequent injections and shows only a partial response. So she is having difficulty in continuing the anti-VEGF therapy, and she is not having good response to the same because she may be missing out on the regular injections as advised. What is an appropriate alternative treatment option as per NICE guidelines? Should we increase the frequency of anti-VEGF injection? Should we switch to an intravitreal steroid? Should we perform pan-retinal photocoagulation, or should we discontinue treatment and monitor? So guidelines suggest here switch to intravitreal steroid implant. So if the patient has suboptimal response to anti-VEGF therapy or prefers to avoid frequent injections, guidelines suggest consider intravitreal steroid as a valid alternative. So, as I mentioned, this completes this part of the chart in terms of the guidelines. Here we have mentioned clearly that if the patient is having a poor response to anti-VEGF, or he doesn't wish to continue anti-VEGF due to the frequent injections, then we should consider switching the patient to an intravitreal steroid implant, which we mentioned, which is the fluocinolone acetonide and dexamethasone. Let's move on to case number 5. We have a 50-year-old female with a well-controlled diabetes diagnosed with center involving macular edema but maintains good visual acuity. What is the preferred management strategy? Anti-VEGF, macular laser observation, immediate vitrectomy, or pan-retinal photocoagulation? Correct answer is macular laser or observation as per guidelines. So here again, look at the terminology: center involving macular edema but with good vision. So here the choice is macular laser or observation. So for center involving macular edema with good vision, macular laser or observation is recommended as per guidelines. As we already looked at, when is the anti-VEGF injection needed? Those are reserved for cases with center involving macular edema with visual impairment. So as we can clearly see, this is the guideline indicated management for center involving macular edema with good vision, and also for non-center involving clinically significant macular edema. We'll look at this in the next case now. But basically, if you look at this part, we have a center involving macular edema with good vision. Consider macular laser or observation and discuss both. Now we have a case scenario 6 where we have a 61-year-old female with diabetes presents for an eye exam. OCT done reveals a non-center involving CSMO, which is clinically significant macular edema, but non-center involving. What is the appropriate management? Anti-VEGF, macular laser, observation without treatment, or vitrectomy. So here, macular laser is the first line treatment for non-center involving clinically significant macular edema. And we see this from the guidelines. This is the other part of that same chart where we have a non-center involving CSMO offer macular laser treatment. Again, they have clearly defined what is clinically significant but non-center involving diabetic macular edema is that does not involve the central subfield, which we discussed in the previous slide, and which basically has a diameter of 1 millimeter. So it does not involve that central subfield, but it still is clinically significant in terms of diabetic macular edema. Case scenario 7. This is how to follow up the patient. So 55-year-old male completed treatment for clinically significant macular edema with resolution of his disease. How should this patient be monitored after the first 12 months of therapy? Should the patient be discharged to the diabetic eye screening program if eligible? Continue monthly anti-VEGF injections, repeat pan-retinal photocoagulation, or no follow-up is needed? The answer as per guidelines is to discharge to the diabetic eye screening program if eligible. And this is also mentioned in the guidelines. After the first 12 months, has the retina got features that makes it ineligible for diabetic eye screening program? No, discharge the patient to a diabetic eye screening program. This is completing the section on diabetic macular edema. And this is one last final case in this regards before we close this session for today. A 55-year-old male with a 10-year-old history of type 2 diabetes presents for routine diabetic eye screening. Fundoscopic examination reveals moderate NPDR without macular involvement. He has no history of prior treatment. What is the most appropriate management plan for this patient? Should we offer immediate pan-retinal photocoagulation? Should we offer intravitreal anti-VEGF? Should we monitor progression and consider review in 6 to 12 months? Or should we do an urgent referral for vitrectomy? So the first 6 cases where I have covered in detail diabetic macular edema, which was one of the sections of those guidelines. The next cases will be dealing with non-proliferative diabetic retinopathy, which is this one. They will be dealing with proliferative diabetic retinopathy. Plus, we look what are the recommendation in terms of statins, fibrates, antihypertensive medications, and glycemic control in the management of diabetic retinopathy, as described in this latest guidelines from NICE. But that's the end of my free session. If you'd like to listen to the full session, which covers those parts in detail, please subscribe to my lecture series. Uh, you can simply email me at mazirules@gmail.com or just WhatsApp me at 0097155 it's just a one-time subscription fees, and all paid subscribers will be given lifetime access to my existing 85 lectures. Sorry for the typing error here, 59. So 85 lectures is the current number, and all my upcoming videos lifelong. So thank you so much.